Hi there, my name's Alan Prost, and what I'm going to demonstrate today is a difference in performance between our standard resuscitator, which we've been using for a long time and been very successful with, the Neopuff, made by Fisher Pickel for resuscitating newborn babies. And I'm going to compare that to a relatively new device on the market, the Inspiration rPAP device. All right, what I'm looking for is a couple of different comparisons. One is how much work of breathing, if we're just delivering CPAP, is imposed by the different ventilators, all right? Because the baby has to breathe back and forth through the resuscitator, drawing in flow through the device, all right? And I'm going to compare that performance between the Neopuff and the rPAP. And I'm also going to measure to see if there's any noticeable differences between a positive pressure breath. So then I'm going to be switching my lung simulator, the ASL 5000, from a spontaneous breathing mode where the ASL is mimicking a newborn's breath, and I'll tell you what those settings are in just a second, and comparing that to a positive pressure breath being delivered. And I'm also going to compare how effectively, because something the rPAP does, which a Neopuff does not do, is it has neonatal nasal prongs or neonatal masks that can fit on the baby to see how effective CPAP is delivered. And I'm going to compare that both with a sealed system and a system with a significant leak. All right. Now, to impose a bit of work of breathing on the system, I've got a 3.0 endotracheal tube. So the pressures measured by the ASL during spontaneous breathing and with positive pressure breathing are going to have an artificially high resistance imposed upon them through this 3.0 endotracheal tube, all right, which could sometimes be used during resuscitations. I'm going to differentiate between the resistance delivered or caused by the endotracheal tube and that imposed by the devices so that we can see differences in performance. So I'm going to have a standardized case here where there's nothing attached, and then I'm going to attach, as I've got set up here, with 10 liters per minute of air going into the Neopuff, and then I'm going to hook it up and allow the ASL to spontaneously breathe through the system, and then I'm going to create positive pressure breaths at 20 centimeters of pressure over 5 centimeters of pressure. And I'm going to show you those graphs and describe you what my findings were by doing this comparison between the two. What I did with this study was I created with the ASL 5000 a spontaneous neonatal breathing model where the patient was breathing in with inspiratory pressures of about 10 centimeters of water pressure, and I had about a 0.3 second inspiratory time. So I had the simulator is drawing air in and out just like a spontaneous breathing patient, and I was able to, with very detailed graphs, indicate how much work of breathing was imposed by the different devices, such as the rPAP here and the Neopuff. So what this diagram is showing us is the very precisely measured negative inspiratory pressures generated to create when the ASL 5000 was creating inspiration. So this is work of breathing imposed by the system. So this is with the 3.0 endotracheal tube, the ASL is breathing in and out, and this is the work imposed by each breath. And as you can see here with the Neopuff, there's a larger amount of negative force required to breathe in, so that is inducing a high work of breathing on our patient. And I used a very special surface area mapping program to actually delineate very precisely the area underneath shaded in blue. You can see with the rPAP CPAP device that yes, there is work of breathing increased by about 76% over the when there's nothing attached. So when the patient was just spontaneously breathing without either device, but it's still significantly less than with the Neopuff. So it looks like the rPAP would be a more effective way of delivering CPAP either through an endotracheal tube if the patient's intubated, or with just a mask, or even with the nasal mask or nasal prongs. So the way that we tested to see how effective the rPAP would be delivering nasal CPAP through the nasal fittings here, and that would be like in this case the nasal prongs, is I created a little bended connection here
with little holes that are mimicking a nares of the newborn, and then I had that simply hooked up to the rPAP. And I did this both with a closed system and an open system with a leak, just to see if the rPAP could compensate if there was any leaks in the system while still delivering the goal of the 5 centimeters of CPAP pressure. And what we found was, of course, that it was very effective. It was quite a simple test, and it compares very favorably with the CPAP. So with the rPAP, I did do a comparison of the work of breathing imposed compared to the CPAP, the VIAS CPAP, which is another common device utilized to deliver neonatal CPAP, usually through nasal prongs or a nasal mask. And as you can see, I very precisely measured that surface area using an application, a computer application that measures that surface area. And you can see that it's slightly less with the rPAP, showing that the imposed work of breathing is quite minimal with the rPAP, even less than with the CPAP, VIAS nasal CPAP. So it looks like the rPAP could be a very effective tool for delivering nasal CPAP to neonatal patients, either A, through the nasal prongs or through a nasal mask. Another element of performance I was interested in with comparing the rPAP was its ability to compensate if there was a leak in the system. So how effective was it at maintaining CPAP pressures, and did it induce work of breathing with a large leak? And what I found was that even with a large leak, it maintained the CPAP pressures very effectively and with minimal to no increase in work of breathing for the patient. So I thought that was an important breakthrough because many neonatal patients have their mouths open or it's not a perfect system. So the rPAP and the VIAS both have the capability of compensating for those leaks, and even if it's quite a significant leak. Now, another important part of delivering effective resuscitations is that you need to be able to give good positive pressure breaths. And what I found when I compared the Neopuff to the rPAP was that the Neopuff gives very good performance. Of course, here's where our baseline pressures going up to 20 centimeters of pressure, and that the inspiratory flows were very comparable between the two devices, slightly higher for the rPAP, but a significant difference is in the expiratory flows. The rPAP expiratory flows are quite a bit higher, and that doesn't insinuate, but that means that the resistance to expiratory flow is dramatically lower with the rPAP. This could be important for a neonatal resuscitation because you've got less chance of air trapping, and you can give effectively higher respiratory rates without the fear of having inverse ID ratios because of the extra time taken to have exhalation occurring when you're making a resuscitation. So I thought that was an important observation.
Now, one of the interesting aspects that I think might be very useful to recognize with the Inspiron rPAP device is how easily it can be changed over to deliver heated humidity. And we haven't been traditionally doing that with the Neopuff because it comes with a sealed pre-bought circuit with specific type fittings, where the rPAP has kind of a more generalized fittings that will fit literally any pre-purchased neonatal ventilator circuit. So you can easily convert this over to deliver heated humidity. All right, so I've just got a regular little connector here. I'm just going to plug in, delivering down to my heated humidity pod. And then we just have our regular ventilator circuit. Now, normally I would have the temperature probes in place, and then this just quickly and efficiently attaches. So now, with the standardized flow from a blender going into the rPAP, I can easily deliver both heated humidity with CPAP therapy via mask or nasal prongs, or when delivering during a resuscitation, positive pressure breaths or CPAP with a mask or an endotracheal tube with heated humidity. And I know traditionally in the neonatal intensive care unit and resuscitation units, we haven't been using humidity with the resuscitators, But I think the rPAP does introduce the fact that it could be easily converted to do that, and that might be clinically significant.
So from this study, my conclusions were that the data does support the conclusion that the rPAP does not induce as much work of breathing as the Neopuff when delivering CPAP through a closed system. That means whether the patient was intubated or using a mask. The data also supports the conclusion that the rPAP is as capable as the CPAP to deliver effective nasal CPAP using either the nasal prongs or a simple nasal mask fitted to a neonatal patient. Another interesting aspect, of course, that's important for resuscitation is its ability to deliver positive pressure breaths. And it looks like the rPAP is just as effective and even has quite a bit lower expiratory resistance imposed on the patient. So it may be possible to deliver a little bit higher respiratory rates without the problem of exceeding the 1-to-1 I to E ratio that's kind of a neonatal limit so that there's less air trapping. So I would like to mention that if you have any questions or you would like to explore this relationship with the Neopuff and the rPAP or using the ASL to do ventilator testing, please contact me. My name is Alan Prost, and you can contact me at the email address below. And I'd also like to invite you to explore any other questions we have. I would like to look at the effectiveness of neonatal pressure support, for example, or comparing the Servo-U compared to the Servo-I ventilator. I think these are some important questions of performance that we should be looking at rather than just the superficial functioning of the controls on ventilators. We should dig a little bit deeper and prove to ourselves how effective they are at the ventilator-patient interactions. Thank you very much. My name is Alan Prost.